I have to move on to the audience participation section. So we are now going to, please try to focus your comments on this session's topic. And again, there are microphones located at the end and I think over here. So some ground rules. You will be given 3 minutes to speak. A light system will keep time and notify you when your time is complete. Oh, I'm sorry. I'm being told you have to go to the mic at the end of the table. That's where the timer is. Ah, all right. The light system works just like a traffic signal. If the light is green, continue speaking. When the light turns yellow, you have 1 minute left for your time, and you should begin to quickly close your presentation. The red blinking light means to stop speaking immediately and return to your seat. Okay. Will the first speaker and subsequent speakers please provide your name, state your disclosures, and provide your comments? Thank you.
Hi, I'm Stephen Butler. I'm Chief Science Officer at Inflection, so I work with the NAVAPRO program. And I wanted to talk real briefly about how well the current systems are able to capture the molecule and the root, and sort of underscore what Teresa Cassidy said. That our data suggest that these routes of administration by molecule and by product are very consistent over time. We have a very large data set, and we're able to see these consistent patterns where snorting is high, injection is low, injection is high, and oral is low, within compound, within product, across the years with very small confidence intervals. And I think that while this is self-report and has those kind of limitations, this kind of consistency in itself addresses some of the validity questions. And I would, so just as an example, the acetaminophen combination products have about 20% snorting and almost no injection. That occurs consistently across since 2008 in our data set. And when you go from oxycodone combination to oxycodone single entity, the injection rate pops right up. And when there are changes within product, and I think Teresa mentioned this, those tend to be contemporaneous with other things happening. For instance, with the introduction of an ADF formulation. And I've got my yellow light, so I'm just going to say one thing that I want sort of clinically for folks to keep in mind is that particularly injection is a very complex behavior, and that folks who inject, in my clinical experience, tend to inject. So if you take away or reduce access to something that they can inject, they will seek something else to inject. And so changing folks' behaviors who are very much into injection is going to be very difficult. And I'd be interested in other people's clinical experience on that. Thank you very much.
Thank you, Dr. Butler. Next, please state your name, title, and any disclosures.
My name is Dan Cohen. I'm the chairman of the Abuse Deterrent Coalition, which is a coalition of ADF innovators, patient organizations, data gathering groups, and others. I'm an officer of a biopharmaceutical company in the ADF space, ChemPharm, and a member of the board of directors of the MedStar hospital system. I wanted to focus my remarks at where you began this morning, both with Dr. Gottlieb's charge to you to focus on the problem, which is IR, and more importantly, to focus where Dr. Schnoll started us this morning. When we're looking at the questions, and these are very good questions that you're dealing with this morning on the force of prescription drug abuse, today's focus should also keep focused on the tree of what abuse deterrent formulations are capable of doing. Many of the answers that were provided this morning talk about futuristic technologies and where we could go, what we could add on, and yet we have to come back to the core of what we can do today. If we want to get these further technologies, we have to have further deployment. One of the slides that Judy put up earlier this morning showing the direction of prescriptions and the percentage of abuse deterrence in them bears mentioning. At the end of 2015, according to NIST data, there are approximately 249 million scripts of opioids issued in the United States. Of those, approximately 9 million scripts were extended release products, and 5.6 million of those scripts had an abuse deterrent in them. Nearly 235 million IR scripts were issued, not a single abuse deterrent in the technology. Approximately 4% of all scripts have an abuse deterrent in it. What you're measuring has the problem of small numbers. We need broader deployment to be able to answer some of the questions that you're asking about today. What we can do today is take a look at diversion. The data that's provided by Radars, NaviPro, and others, the observational data, clearly shows that products with an abuse deterrent technology in it have a diversion benefit. Whether we can actually show the answer to Dr. Schnoll's question of will abuse deterrence deter intranasal and intravenous abuse will have to be deferred to the point where we have broader deterrent deployment of the technologies themselves, because right now, with so much product available on the market that is easily abusable, abusers do not try and defeat the product as much as they try and move on to something that is easier to abuse. We have an early stage right now of abuse deterrent technologies. We need broader deployment of these technologies, of these earlier methods, to be able to get the more advanced products that you're seeking and that industry would like to deliver. Thank you.
Thank you, Mr. Cohen.
Good morning. I'm Jack Henningfield with Pinney Associates in the Johns Hopkins School of Medicine. Let me comment on the questions concerning distinguishing 80 molecules and formulations. The challenge for surveillance is much bigger than that. It's distinguishing whether the people using were prescribed patients or not, and whether the molecules were illicitly manufactured prescription products or illicit street products. And when they're lumped together, as they often are, even in reports by different agencies, it can lead to wrong solutions and mischaracterization of the problem. And a couple of examples illustrate this. Oftentimes we see reports about how many people use prescription opioids as their first opioid in leading to opioid abuse. Probably most of those were not prescribed patients. We don't even know how many of them that were reporting a prescription opioid were actually using illicitly manufactured prescription opioid. Yet when we lumped it all together, I think we mischaracterized the problem. We don't help with the solutions. And blunt instrument approaches of telling doctors to just suppress your prescribing, that probably does hurt pain patients. It probably hurts lower income people, and minorities the worst. We already know that. So this is really important at that level. There are no simple solutions for this, but I think that at least federal agencies, I think if they're more consistent in how they talk about the data and the limitations of the data. At the College on Problems of Drug Dependence meeting a few weeks ago, more than 1,000 experts, a lot of them were talking about the same data differently. Nida's Nora Volkol, I think, had a huge advance when she talked about prescription, heroin, and fentanyl and other synthetic. That's a huge advance over at least breaking it into 3 buckets. So I think we've got to recognize the limitations of the buckets that we're now collecting the data in. We don't need to wait for a lot of new measures to do a better job and be more consistent with how we're doing it. But we do need consistency across the agencies. 2 other examples are oxycodone, probably the ultimate Kleenex. We don't know how many people that actually use oxycodone were using OxyContin, but it's all lumped together. So we've got to do a much better job and focus on, were they prescribed patients, and was the so-called illicit or prescription drug fentanyl manufactured in China on the street, which is no more a prescription drug than heroin? Or was it illicitly manufactured prescription drug? These are tough challenges.
Thank you.
Good morning, Paul Copland from Purdue Pharma. I'm humbled to speak in front of such an illustrious panel of experts. I wanted to share some insights as a sponsor, and my team and I have submitted maybe 7 reports to the FDA over the last 7 years. We've been amazed at the rigor and insight with which FDA has reviewed them, but that has given us some thoughts. So 2 key points. The first one is consistency of effect, and the other one is the importance of diversion. So consistency of effect has to do with each of these surveillance systems has the limitations that was well laid out in the beginning presentations by FDA. And that's been recognized from the outset when we presented these as proposed data sets to be used in post-marketing studies of ADFs or OADPs in 2010. And the idea was to compensate for the limitations of each data source by looking at maybe 5, maybe 10 data sources and looking for consistency effect across the different data sources. The limitation of, say, poison centers, which are we all recognize, at the same time the limitation of treatment centers, if we see a similar effect across 5, 6, 10 data sets, that helps to support. Also, if we see a consistency of effect in Dr. Degenhardt's studies in Australia, using different kind of surveillance systems, and the Canadian study at a different time period, that again builds a consistency of effect, and we think that's an important consideration. The second issue about the importance of diversion. So one of the questions was, what does street price or diversion events or doctor shopping tell us that's of use to the FDA? Well, we think that if you can reduce diversion of an opioid, that's the black market for an opioid, that's a very important goal. Why is that an important goal? Because that doesn't detract from the importance of measuring and understanding the risk of addiction in patients. But the black market in and of itself, if that can be reduced, has important consequences. Firstly, that black market is all going to for abuse and addiction. And that's what's resulting primarily in the overdose and the deaths. So if we can reduce that, it improves the overall benefit-risk balance of the opiates, which is what Dr. Gottlieb was referring to earlier. Secondly, it improves the patient-doctor relationship because the doctor isn't always being scammed by the patient to try to get drugs that they can divert. It also improves the situation for the patient because the patient doesn't always have a temptation to divert that opioid onto the black market where they can sell it. And lastly, diversion is very important because it helps us with causal inference. Because one of the ways we can differentiate between different interventions is by looking at supply and demand. Some interventions affect demand and others affect supply. My time is up, so I'll stop there and perhaps get back when we discuss causal inference later. Thank you.
Thank you, Dr. Copland.
Good morning. I'm Steve Pasick from Collegium. I just wanted to point out the problem of low uptake has been mentioned a couple of times, and just wanted to provide a little bit of additional information there, because what we have here is a real catch-22, but it's also skewing the population in interesting ways as well. So I think one of the biggest problems we have is that you have payers who have fail-first policies, so that people have to fail 2 non-ADFs before they can get access to an ADF. That's keeping the numbers in the marketplace down and making it difficult for these existing data sets to evaluate the impact. But in addition, it's probably also skewing the population some. Because if a person is going to develop a problem that involves manipulation of the dosage form, they're going to have 2 opportunities to do so before they ever see an ADF. So that the people that you can then study on ADFs may not be representative of people who might have gotten those formulations earlier. Additionally, I would just like to say that I think all of the existing data sets also have the problem of not really reflecting the use of ADFs as part of elevating the standard of care and how opioid therapy is practiced. And so all along, I think we've had a problem where people are not adequately screened, their risk is not ascertained, and then a delivery of opioid therapy in a particular way that employs the PDMPs, psychotherapy, ADFs, urine drug testing, etc., may or may not get applied in a way commensurate to that person's risk level. And so I think one of the problems you have with these data sets is you might see ADF use, but you may not see it as part of an overall plan to practice up to an elevated standard of care. And I think that's something that may be important if you do some prospective trials, perhaps in a registry type format or whatnot going forward, where you would also record those things. Because I think studying the impact of ADFs in isolation with clinicians who may be doing everything else wrong but written a prescription for an ADF, I think that's a tall order to expect that the ADFs will make up for all the other gaps in practice. Thank you.
Thank you, Dr. Pasek.
Great, thank you very much for a very informative and good discussion to get us out of the gate. So now we're going to take a 15-minute break, and we'll reconvene promptly at 11:05. Thanks.